Good evening, all. Thank you very much for joining this early. We will start very soon. I will contact the consultant going to be giving us the lecture to join in so that we can start from as early as possible. Thank you very much.
Ìfẹ́ kúṣẹ́ o.
Yes, ma. Good evening, ma.
Ẹja ti wá àgọ́ tán fún wa. Ó sì kọ ẹyọ kan ṣo. Ó sì kọ ẹyọ kan tán fún wa. Tí àwọn olóògbé tán ní ilé ìwé tó gbé fún wa.
Hello, ma. Yes, ma. Good evening. Yes, good evening, ma. Yes, ma. I call it. Thank you all once again. Good evening, sirs and ma'am. I appreciate our efforts in joining early. Our lecturer today is trying to tidy up things. She will join us in next 5 minutes. So please let's be patient, and I promise we will have a good time today. Thank you very much. So while we wait for our lecturer to join us, I would like to call on Mrs. Makinde to please give us opening prayer so that we can continue, so that our time the consultant join us. Just continue from there. Thank you, ma. Mrs. Makinde, please unmute.
Call here. Share your music. Share your love.
Okay. Okay. Thank you very much. Our lecturer is here. I will really give an opening prayer so that we can start. In Jesus' name, Father, we thank you, Lord, for this evening, for making us to see the last Sunday in the year 2024. We pray as we listen today to learn about our head, Father. Help our lecturer to give us the information that we need, and help us also to make good use of the information. In Jesus' name, we are prayed. Amen. Jesus' name, Father, we thank you, Lord, for this evening, for making us to see the last. So we have in our midst Dr. Dolapo ADEDAPO, a consultant psychiatrist, who has graciously granted us this privilege to educate us about this particular condition that all of us we need to know about for ourselves and for our relatives, so that we can be able to identify this problem and be able to know what to do with it. So without further ado, I would like Dr. ADEDAPO to take the stage and give us the information. Thereafter, we can ask our questions. Thank you very much.
Thank you very much, Dr. Oladunjoye. Good evening, everyone. Yeah, so I should start by apologizing for coming in few minutes past 7. I mean, I thought based on the time difference, I felt I'll be joining in by 9 p.m. here. And that was a mistake on my side because it's supposed to be 7 p.m. here. So that's the reason for joining a bit late. So my sincere apologies. Thank you. Yes, so I want to start by appreciating Dr. Oladunjoye for this opportunity, and I celebrate everyone present this evening. I pray that by the grace of God, the statement long life and prosperity for us would not only be long life, but we would also experience prosperity in our health in Jesus' name. Please, can you see my screen? Can you see my screen, please?
Yes, ma'am. We can see your screen.
Okay, thank you. So if I may ask, what can you see, please? Anyone?
We can see two tree, one green and one gray, one fresh and one dry. Yes, I mean, that's use that word.
Okay, thank you. And there are 3 trees. Can you see the 3 trees?
Oh, 3, yes.
Or just
I can
2?
see the 3, yes.
You can see the 3. Okay,
yes,
thank you. I just want to be sure that my screen is visible. Okay,
yes.
so I would start with a case vignette, and it's about someone, I mean, and that's fictional. I'm not aware if there's anyone bearing this name, but I intentionally put together a Yoruba and Hausa name, and I think that would be helpful so that it doesn't 100% correlate with somebody's name. So this is the case vignette, and I'll just read, and then let's try to go. Hello, can we mute, please? We seem to have some interference. Can admins please mute, or can someone please mute? Okay, thank you. So the case vignette is about a fictional name, Mrs. Ajani Suleiman. She's a 70-year-old woman who just celebrated her 70th birthday, which was well attended by family and friends. She's a stroke survivor, and everyone was grateful she recovered almost fully without noticeable weakness in any part of her limbs. Her blood pressure and blood sugar are now well controlled as her nurse, as a personal nurse, administers her medication after she was discharged from the hospital. All her children who lived in diaspora came home for this grand celebration and were happy that their mom was alive to witness her birthday. They, however, noticed that she had difficulties remembering important past family occasions and traditions. She was quite muddled up with storytelling, a well-known hobby. That's her well-known hobby, and often avoided answering pertinent questions and preferred to describe items rather than name them. When they tried to suggest some words, she became mildly irritable towards them and avoided the conversation altogether. She struggled to make bank transactions sometimes and also argued with her local vendors. Following further discussion with her housemate, she revealed that this has been ongoing in the last 1 year and has progressively worsened. However, she's still able to make her meals and go about her daily activities without much ado. She visited the hospital with her children and she was diagnosed of dementia. So that's the case vignette. And then we look at dementia, what dementia is, the introduction. Would also look at the epidemiology worldwide, and then come down to Nigeria, and afterwards take a look at the risk factors, how the types, how it can be managed, and prevention, and finally would return to this case vignette, and at that point would make it interactive. Okay, so I just want to be sure you are hearing me. Are we all together?
Yes, we are hearing you very
Okay,
well.
great. Thank you. So the introduction, we are looking at dementia. So what is dementia? So dementia is a syndrome. When we talk about a syndrome, that is a group of symptoms, really, associated with decline in the functioning of the brain. And because there's a decline in the functioning of the brain, it leads to problems with memory, problems with thinking, language, mood, and behavior. So when we talk about dementia, it's not just about normal forgetfulness. So forgetfulness can be normal and it can be abnormal. We all know that at one point or the other, we have forgotten something in the past, even something that happened in January, either because we intentionally choose not to forget it and to remember, and over a period of time we completely forgot, or even unintentionally, somehow we just realized we couldn't remember some details about certain activities while others would remember. And that can be normal. So when someone is, forgetting something, it does not necessarily mean that the person has dementia. And then still talking about dementia, it's not part of normal aging. When we take a look at that picture, the first pictorial representation at the beginning of this discussion, I think there were three trees. One was very green. And the truth is that when we look at the other two, the density of leaves and the freshness of the leaves the density seemed to have reduced. The freshness also worsened, not so fresh anymore. And some of this can be part of normal aging. The skin can wrinkle. Aged people can somehow begin to forget some things. So there's a process called normal aging. But there's a point when you begin to think this is beyond what you would call normal for someone. And then you begin to wonder, is this person experiencing dementia or not? So it's not just about forgetfulness, but it also involves changes in mood and personality. And apart from that, it significantly interferes with daily activities and also with the person's decision-making process. So we quickly look into epidemiology. Can we mute, please? Can we mute, please, so that we all can enjoy it? Thank you. We quickly look into the epidemiology. I mean, worldwide, about 55 million people are affected, and this is what World Health Organization facts from World Health Organization. About 55 million people are affected with dementia worldwide, and 6 out of 10 of these 55 million people that are affected are from low and medium income countries, and that includes That includes Africa, and that includes Nigeria. Dementia is also known as known to be the 7th leading cause of death worldwide, and one of the major causes of disability in older people. Now we come down to Nigeria. There's a study by Adeloye et al. In 2019. And it's a systematic review. The study looked into other previous studies that have been done in Nigeria and pulled that together and tried to find what was significant in Nigeria and what the epidemiology of dementia looks like in Nigeria. And the study found out that, so it was 2019 study, found out that 1 out of every 20 among those who are 60 years and above actually have dementia. 1 out of every 20. So counting from age 60 and above, 1 out of every 20 was diagnosed of dementia. And then it's more in females. When we also look at worldwide studies as well, it's actually more in females. And if you ask me why, looking through literature, different literatures, I understand that somehow females or women live longer than men. And because dementia most of the time is a disorder of the aged, so that will help us to understand why it's more found it occurs more in female. And that's sometimes twice more common in females than males. And then it's also more common in the northern part of Nigeria than the southern part, and also more common in people with history of alcohol intake and also stroke. So that's just bringing out a part of the study done in Nigeria in 2019. So quickly, we look at the risk factors for dementia. And the first is age. I mean, it's more common in those who are 65 years or older. There's a set that, we call early onset dementia. Those are those that develop dementia before the age of 65. And I think that's just in about 9%. So the remaining 91% are actually 65 years or older. So age is a risk factor that I would say cannot be modified. Obviously, it's not modifiable. But there are other risk factors that can be modified. And then we have hypertension here. That's, high blood pressure. I'm sure that this word is obviously not new to us, considering the group that we are in and considering the great work Dr. Ladunjoye has been doing to, help us understand hypertension more. But hypertension is a risk factor for dementia. And then diabetes also, when your blood sugar is, higher than normal and it's not well controlled, is also a risk factor. Obesity and overweight has been known to be a risk factor. Smokers, those who have a previous history of smoking or who currently smoke, also those who take lots of alcohol, sedentary lifestyle. We'll still come to discuss more of this, but sedentary lifestyle has been known to be a risk factor, and also social isolation and depression. There's an important risk factor that is not here, and those are the two that really cannot be modified, and that is family history. Family history is also a risk factor. So there's someone in the family being with a diagnosis of dementia. I mean, it could, run in family, and different genes have been implicated. So we should understand that age and family history, there's nothing you can do about that. But the rest of these risk factors, there are things that we can do about it. And, doing something about this and ensuring that our blood pressure is normal, if you're diabetic, your blood sugar is well controlled, you watch your weight, avoid smoking and things like that, all that can significantly help to reduce the likelihood of coming down with dementia in old age. Okay, so types. I just put in the types of dementia. There are more than this. So these are just like the common ones. There are some other ones. And that's Alzheimer's dementia. I mean, they call it Alzheimer's, really, Alzheimer's dementia, and that's the most common. And after Alzheimer's, the next common one is vascular dementia. And then I'll quickly talk about vascular dementia. Okay, before then, I mean, we've got frontotemporal dementia, dementia with Lewy bodies, Parkinson's dementia, mixed dementia. Now, not to bore us with the names, I'll just quickly speak about vascular dementia, because of the peculiarity of this group again. So vascular dementia is often common in people who are being managed with high blood pressure, especially when it's not controlled. Even sometimes when it's controlled, that could occur. And not just high blood pressure, also diabetes, and with those with abnormal lipids. So when we see any of these three and the person is coming down with dementia, we'd also look into the progression of dementia, really, because in vascular dementia, we call the progression it's stepwise. So more like the person deteriorates a little and then stabilizes over a period of time and then deteriorates again. So the dementia symptoms worsens and then it stabilizes and then it worsens and then it stabilizes. But for Alzheimer's dementia, it just progressively worsens over a period of time. So this is just to let us know that there are different types. And then when it can be mixed when it's combined with when we have more than one, type of dementia occurring in a person. And then quickly we look at the early presentation of dementia, and that's just the common presentation of dementia, the common early presentation. So first is memory loss. Memory loss. So that's more like what we call undue forgetfulness. So you realize that the individual begins to forget a lot, and it's more than what is expected, more than usual, that people begin to suspect what's wrong with this person. She seems to be forgetting more than usual. So we call that undue forgetfulness. It could also come with problems with concentration. Problems with concentration. So when we talk about problems with concentration, that could come with maybe losing some items or misplacing things. Just misplacing things. So the person, the elderly person keeps looking for something over and over. Oh, I thought I placed my money here, and then meanwhile she placed it or he placed it somewhere else. Part of the early symptoms could also include finding it difficult to solve problems or make decisions, or even finding it hard to carry out daily tasks. So general daily tasks can become a bit difficult for the person. Ideally, daily tasks should not be tedious or arduous, but in the case of dementia, because they have problems with concentration, daily tasks can be more tedious, can be more difficult. And then we might also realize that it might become difficult for the person to find the appropriate words when communicating. Yes, so difficulties with finding the appropriate words. We call that word finding difficulties. And then instead of naming the item, they start to describe it because they've forgotten the name of the item. But then in the early stages, when you remind them of the name, then that helps. Okay, but for some of them, they can, even get angry when you do that. And then they can also get confused during the early period about the time and about the location where they are. They can be a bit confused. And, in late stages, some people completely get missing and they are not allowed to. It would not be advisable that they leave the house as they can get missing. Then there could also be changes in their mood. Some can really get irritable, which is understandable because at the early period, they tend to understand that this is unusual of them. They tend to understand the difficulty they are facing, and it can be a difficult place to be, to suddenly realize that you can't remember simple things and that you're not able to carry out daily tasks. So when they start feeling angry, when they start feeling anxious or sad because of problems remembering a number of these things or problems getting involved with daily activities, we should know that it is understandable for them. So we shouldn't blame them. For those of us that have elderly ones at home, we shouldn't blame them that, oh, mommy, why are you irritable? You get really angry these days. When we remind you of something, you really get angry and things like that. So it could also come with personality changes. There might be changes in their personality. And some of them could even withdraw, from social activities and become less interested, possibly because they feel embarrassed that they are not able to remember some of these things. And then late presentation, the memory problems could worsen. Communication could now be much more difficult, not just what finding difficulties, but they might really find it difficult to communicate their mind to others. Many of them could develop mobility problems at that time, and then even behavioral problems could come in as well. Behavioral problems could come in. The irritability could get worse. They could, develop problems with sleep and so on. I mean, different kinds of behavioral problems. It could really get worse that they could become incontinent. At that time, I mean, this late presentation usually requires more care for them because at that time they would not be able to care for themselves anymore. It would involve neglect because they can't even remember how to bath again, or they might even forget that they've not had their bath that day. Initially, when common early problems could just include things like maybe forgetting to take their breakfast, but they might still remember to bath. But when completely deteriorates to self-neglect, then some of them would need 24-hour care. And that's why, some people are now left in care homes, nursing homes, and places like that. Some could develop problems with swallowing and, aspirate. So when I mean aspirate, they could go, so to speak, the food going through the windpipe rather than going through the esophagus, and it could lead to chest infection and all that because they're also not feeding well. Because of poor appetite, they could experience poor appetite and then they are not feeding well, and because of that, there could be weight loss and all that. Often at this time, also for those of us that have elderly ones, elder abuse is usually very common. Even in nursing homes and even in, when people leave them with house helps, they can be abused. So it's always good to keep an eye on, our loved ones. Even under our roof, when they are there, they can be abused if we don't, keep an eye on them. And then we'll take management and then just come down to discuss more of prevention, how dementia can, be prevented. So management, of course, coming to the hospital and having to examine them, they would need investigations. While investigating the elderly ones, would be looking out for, risk factors. What's their blood pressure like? What's their blood sugar like? What's their lipids, level like? That's the fat level in the body, the cholesterol level. Um, brain imaging, what we call magnetic resonance imaging, can also be very helpful to look into the the brain, and let's see what exactly is going on in the brain. Is there reduction in density and things in the size of the brain, and density in some parts as well. And then also there are some, not to bore us, but there are some questionnaires that can also be administered also to check. Not to bore us with those questionnaires, I won't want to go deep into that. But management would involve investigations generally, and then managing the identified risk factors. So there might be some risk factors that could have predisposed the person to it, then that has to be managed. Management would be individualistic. So the need of patient A is usually different from patient B's needs. So it will be needs and person-centered, depending on the needs of the person, depending on the risk factors, depending on the stage as well. And then medications. Talking about the role of medications, I mean, there are different medications. I mean, when we talk about medications, I don't know, maybe I should start mentioning the names of these medications now. Medications such as rivastigmine, memantine. I don't want to go into the names per se, but let's talk about the role, which I think is what would be very helpful. Medications on its own would not stop dementia. So it would not return the patient back to the previous state. For some people, when they start medications, they could say that there has been some improvement in some of their symptoms. Some would say improvement in memory, but in actual fact, it doesn't get to return the person back to his usual state. The way medications would return blood pressure back to normal. So in dementia, medication does not return the person back to normal 100%, but it can help to reduce how fast or how quick deterioration happens. It can help to reduce how fast or how fast the situation can worsen. So if the situation is supposed to worsen and lead to death within 5 years, medication can prolong that such that the deterioration is slower. Also, in the role of medications, medications can also help with sleep and also help improve behavioral symptoms that could be associated with dementia. And then for someone being managed for dementia, they would need lots of social and family support. And that's the truth. At that time, they need lots of love and care. I know that the burden of care, the stress and the burden that comes with caring for someone who is almost completely dependent, an adult who is almost completely dependent on you, can be a lot. And that's why it should not just be one person caring, one family member caring for this elderly person. Preferably many hands would be very helpful. And I'm saying this because I know we have lots of aged people around us. So it's good to look into having to support them. And then lifestyle adjustments. If we remember, I did mention sedentary lifestyle as a risk factor. Sedentary lifestyle would, it involves things like not so much activities, physical activity, mental activity. So for someone who is being managed for dementia, there's a need for adjustment in his or her lifestyle. And that would also include, apart from ensuring physical activity, apart from also looking into appropriate mental activity, it's also important to, for those that smoke, to stop smoking. For those that take alcohol, you could look into stopping alcohol. I mean, stopping, if the person is dependent on alcohol, permits me to use the word dependent. That's a word that can be used interchangeably with the word addiction. Then it's better to look into how to gradually reduce the quantity of alcohol the person takes, or even, preferably having professionals taking care of this so the patient is able to stop alcohol. And then what we call environmental modification. A lot of times people with dementia are vulnerable, and elderly people generally are vulnerable or at a risk of having falls, falling down. A lot of them have broken bones. The bone density is reduced and things like that. So you see them having fracture of the neck of the femur and so on, or even different parts of the body. I mean, I remember my grandma one day climbing the was it a chair or a stool, and wanted to pick something, and then she fell and broke her arm. So environmental modification is very important. So things like ensuring that the house where the patient stays is well spaced, such that there are no obstructions on the way, like stools. Right now, if we have stools on the way, you can easily move them to the side without any problem. But for an elderly person, they could trip over the stools, really. There could be things like signs for bathroom, signs for toilet, signs to the kitchen, so that in case they forget and they want to get to the toilet, the signs can easily direct them appropriately. And when you're putting in the signs, it's good that they are big enough, because sometimes they could have problems with sight and so on. And then, avoiding wet floors where they can trip and so on. Clearing the house of clutters, that's still part of it, because sometimes there can be risk of fire. So managing the risk is also very important. Like I said, it's person-centered. Management is person-centered. So the risk is different in each person, for each person, because it depends on the situation at home. So based on the different, there's risk of fire. That's for someone who, is cooking and forgets, because of the forgetfulness, forgets that it's cooking, and then there's a fire hazard, there's smoke everywhere, and then people rush in to help. That kind of patient should not be encouraged to cook, except with supervision, except there's someone else there at that time. There's even the risk of having burns. Some of them could pour hot things on their body and so on. There's a risk of getting lost. So if they have to go out, then someone has to go out with them. Someone has to be with them. So it comes with different risks. And there's also the risk of abuse. There's the risk of financial exploitation. They could make transfers of large amounts of money. They could give out change wrongly and so on. So we need to look into peculiar risk for each person and see how best we can manage it. And then there's what we call cognitive stimulation therapy. When we talk about the cognition, we are talking about the thinking, we are talking about the memory, and so on. So when we talk about cognitive stimulation therapy, things like how the mental health how the mental activity, that's the word, can be stimulated. A lot of time when you go to maybe the park in the morning, or even in less populated area, you see these elderly people playing draft, or you see them reading newspapers early in the morning. What they are trying to do is that they are trying to ensure mental activity. They are trying to continually stimulate their brain. It could also come with things like maybe crossword puzzle, drawing crossword puzzle, and so on. For those that love to play chess, for those that love to play Scrabble. And this again would also depend on the stage of dementia, because you possibly would not tell someone who is in his late stages to come and play Scrabble. Obviously, it's not likely he would be able to do that. But I mean, the therapists, the occupational therapists, or even psychological therapists help to administer this cognitive stimulation therapy, and they do it on a consistent basis. And when they do it on a consistent basis, it also helps to improve memory. And then art therapy, some love to draw, that also helps to stimulate the brain. Aromatherapy, there's also what's called pet therapy and so on. So prevention, which I think it's an important part we need to look into. First, prevention, be physically active. Very important, very important. Right now, I mean, I've mentioned that there are some things you can't do anything about. Age and family history. There's nothing we can do about that. But right now, we can be physically active. Don't sit on a particular spot all day. Sometimes some of us, maybe we work in the bank, maybe we work in the offices, and we're just seated all through. In between, take breaks and walk around. During break, don't just sit down. Walk around. That would be very helpful. Rather than having to maybe drive. I mean, if your place of work is not far, why don't you walk? Except maybe the time is not, I mean, maybe the time is short or something. But if not, you can walk. You can take walks. That's very necessary. And then I've also mentioned things like crossword puzzles, Sudoku. That's ensuring good mental activity. The truth is that research has shown that people who continually ensure, and please note it, continually ensure good mental activity, they are less likely to come down with dementia. So when we look at professors, those who continue reading, they continue to write papers till old age. The truth is that the more new things that they learn, it's like there's more connections, more brain cell or neural connections in the brain. So that kind of help to rejuvenate the brain again. Because as we grow, like I'd mentioned earlier, sometimes the brain cells and neurons begin to degenerate. But you can imagine you getting involved in more mental activity, some of this, brain cells again can connect. So good mental activity is very important. Avoid alcohol and smoking. That cannot be overstressed. That is very important. And then healthy diet. Healthy diet would, help your blood pressure. And that's the truth, because we know that when you take lots of salt and things like that, that could affect your blood pressure. So healthy diets, when you take healthy diet, that would also reduce the amount of fats that you take in, things like butter, and so on. Here, people take things like cheese, lots of cheese, and so on, which is usually not too helpful. So, but healthy diet would include just involves balanced diet, and make sure let's take lots of fruits also. That helps. There's a formula when you have clocked 40. You should have less of carbs, less of carbohydrates, and take lots of fruit. Even though you still need carbohydrate and you still need protein, but the carbohydrate should not be so much in high quantity. All these have also been known to be very helpful. And then maintaining your blood pressure. Take your medications for blood pressure. Take, your medications for diabetes, and, medications for high level of cholesterol or lipids, or the bad lipids. So please continue with, regular checkups in the hospital. Excuse me, please. Continue with regular checkup in the hospital. Participate in social activities. Social activity is very important. Very important, because it also helps your mood, it helps memory, it helps you to also learn new things. Now, for those that are already struggling, struggling with remembering things, you can keep a journal of appointments and tasks. So I will now go back to the case vignette now. Sorry, please, can we mute? Very soon we'll be unmuting though. So that's about prevention, and then regular hospital checkup. We'll now go down to the case vignette, and we'll possibly take it that there are 4 slides. And based on everything that we have discussed, I will appreciate if we can maybe identify some risk factors in this woman, Mrs. Ajani Sulaiman. From the first page, can we identify some risk factors and maybe some protective factors as well. Maybe some risk factor, maybe some protective factors. So let's start from the first page. I would be grateful if we all can participate and discuss this. Actually, this interaction is very important. So the floor is open. The floor is open to everyone. This first, can you see this slide, please? This case Vignet, the first slide.
Yes, we can see it.
Okay. Can we try to identify some, based on our discussion, some of the risk factors in this woman? Okay, so I think someone has posted in the slide. I would have loved that we speak so that we can have, we can interact together. But someone has posted, I think Dr. Oguniyi, thank you very much, Dr. Oguniyi. So he did paste, so I have to go back to the charts now. That just popped up. Okay, age. So this woman celebrated her 70th birthday. So she's older than 65. Age. And then she's a stroke survivor. Please, can you still see my screen?
Yes, you can see the screen.
Okay, thank you. And then she's a stroke survivor. So she had stroke in the past. Okay. And then, it's also in the slide that her hypertension and diabetes are now well controlled. So the statements are now well controlled, most likely means that it wasn't well controlled before. So when we say are now well controlled, even having those two conditions are risk factors, not to talk of when they were not controlled before. Okay. So I'll now move to the next slide. I mean, I tried to check the charts and somehow I've left my page, my presentation slides. I'm not sure how to go back there. God help me. Okay, let's see my screen. Okay, I think that should help. My screen. Yes, I'm there. Okay, so and then I'll move to the next. Is there any protective factor here? Is there anything like what can be of help to this woman from what we have seen? I think I can identify one or two so that we identify that before leaving this slide. Please, let's talk. Let's unmute and speak. Let's make it interactive, please. Anything that we think will be of help, about 2 or 3 will be of help to this woman just from this slide.
Let's unmute and contribute, Sam.
Of course, she has family support. There's family support.
Yeah.
Family and friends.
Yes. Thank you very much, sir. Very correct. Family support. I mean, her birthday was well attended by family and friends. So that tells us that she's got some degree of support, social support. She's got some degree of social support, okay? Is there something else that we think? What did you say, please?
The medication is being well adhered to.
Yes. Thank you very much. That's spot on. Thank you very much, Mr. Taiwo Giwa. I don't know whether it's doctor or Mr. or Prof. Permits me to anyway. Okay, thank you, Mr. Giwa. So yes, the medication. So the medication is now being well controlled. Please, if we are not speaking, we can mute. When we are speaking, let's unmute. The medication is now being well controlled and administered by someone. So she's unlikely to mix up medications here and also be at a risk of overdose because there's someone that comes to give the medications. Okay, so we move to the next slide about our patients here. I don't know why my slide is not moving. Wow. My slide is not moving. I don't know.
Take it from the slideshow and use so that I can share.
Okay, so I can
That is
move it from the
slideshow.
slideshow. Okay,
Yeah.
so let me do that. Okay, yes. Okay, so can you see the next slide? Okay, are there protective factors here? Are there risk factors here that we can pick, or even symptoms? Because this, I think this page really talks about has symptoms. Can we look at the
Yeah.
symptoms and pick out some symptoms from here, please? Let's unmute. Let's feel free, please. Let's feel free. Let's unmute. Symptoms, anyone?
Difficulty in remembering
Yes.
occasions. She was modeled up with storytelling.
Okay.
She avoided answering pertinent questions
Yeah.
and preferred to describe items rather than name them.
Yes. Thank you very much, sir. Thank you very much, sir. That's very accurate. So she had problems remembering past occasions, important family, occasions and traditions. And then her personal hobby, which has to do with storytelling, she was modeling them up as well. So this kind of woman, we talked about needs centered care. This kind of woman would be good to have family around her telling her stories about things that happened in the family. I mean, good memories, things that happened in the family in the past, and generally stories, Cop Campbell stories. She would really enjoy it, and that would help her quality of life as well, and also help her mood, because that's her hobby, that's what she enjoys. So having people do that around her would be very helpful. And then she part of the symptoms, she also often avoided answering important questions, basically because she can no longer remember. And then because she cannot also remember the names of things, she would rather describe them. She would rather describe. So you hear things like that thing, if it's in Yoruba, I don't want to speak Yoruba, but let permit me to say that you hear things like kiniti mofinwe. So that thing used for bathing. So they can't remember the name sponge, they can't remember the name soap. So they would use a thing to describe it, something like that. Okay. Then there are also more symptoms here. Can we look into more symptoms? I think we have about three or four thereabout symptoms. Anyone, we can unmute. If you have not spoken, please unmute. If you have spoken, can also mention. Then we just go into questions.
Highly irritable.
Yes. So her mood is now affected. She's become irritable. Yes. Thank you very much, Ma. And then did we notice the last statement? She's okay. Go
Conversation.
on. Yes, avoiding conversations. Yes. Then the last line.
Arguing.
Local vendors. Thank you very much, Ma. That's spot on. Arguing with local vendors. So possibly she's giving change wrongly, or they've given her something and then she's saying, no, that's not what you gave me. That's not what you supplied. You've not supplied bread this morning to my house. Meanwhile, the woman had supplied bread and came for her money, but she's giving the wrong amount of money. Problems with bank transactions as well. So we need to look into that for them. And then just to make it quick, because of time for questions, we found out that this has been going on in the last 1 year and has worsened. But it looks like more of the early stage, because we see that she's still able to make her meals, she's still able to go about her daily activities without much ado. The good thing is that they visited the hospital, she got the diagnosis, and I'm sure the care will go on from there. So now would welcome questions. Thank you. If we have questions, suggestions, additions, before the feedback, we'll come back to this. Sorry. Okay. Questions, please.
Thank you very much, Mark, for the lecture. We are very grateful. At least we have detail on so many parts that we need to work on. And interestingly, we have doctors in the house more than non-doctors. So
Oh, okay.
I want to leave it for to ask the questions. But what I just want to to open the floor is that please help us talk more about the tools for diagnosis that you mentioned earlier, especially
Okay.
those we can use for people that are NELED and the one we can use for people that are not NELED, especially in our environment, so that we're able to make as accurate diagnosis as possible and manage accordingly. Thank you. And also maybe because usually these people are usually this issue of elderly women being termed as witches, being I'm sure even recently one still happened somewhere in this or if I remember very well when they start meeting, say that so is the one that killed some person, the one that killed that, and then the next thing person is ostracized or even some of them will be killed. So just help us
Mm.
talk more about that issue of stigma, issue of abuse. You mentioned the abuse too. Thank you very much.
Okay, thank you very much, Dr. Oladijoye. Apologies, I actually didn't know that we have more doctors in the house, and that's why I, tried to avoid the medical jargons, and also didn't go so deep into medical aspects. But now that I'm aware that we have quite a number of doctors in the house, so I'll start with your first question. So the tools that is used for some of the questionnaires used for diagnosis is the mini mental state examination, which is very common. The mini mental state examination. The mini mental state examination is different from mental state examination because this time it comes with a questionnaire that is called over 30. It's called over 30. And when it's less than 10, it's suggestive of severe cognitive impairment. Then when it's between 10 to 19, 11 to 19, that's suggestive of moderate cognitive impairment. And then when it's between, so I said 11 to 19, okay, then when it's now between 20 to, some would say 26, then you would say that's mild cognitive impairment. You would actually see different scorings online. Some would tell you less than 10, that's 0 to 10. Some would tell you 0 to 9, and then it's 10 to 19. So there might be a bit of one overlapping between the scores. You would always see different ones, but basically I just use the 0 to 9, 10 to 19, and then 20 to 26. So the mini mental state examination is very good. That's often very helpful. The other one that I know is helpful is what we call the Montreal Cognitive Assessment. But the concern with MOCA, so we just call it MOCA. The bit of concern with MOCA is that, I think there's a place where you are asked to name camel. And in this environment, our mamas might not know what camel is. Camel, lion, and then I think there's one or two other animals there. And then there is it goose or geese? Those ones they can call it duck. Lion, I think they should know kiniun. So camel, I'm not sure they would know. So I'm just thinking, but apart from that, Mocha is even very sensitive in picking cognitive impairment than the mini mental state examination. That's the truth. It's very, very sensitive in picking better than MMSC. So those are the questionnaires that is often used. And then also there could also be, those are questionnaires for depression because dementia and depression can occur together. That's if for someone who already has dementia, and then if the person is now depressed, there might also be need to administer questionnaire for depression in old age. But I mean, let's just leave it at dementia. I'm trying to remember the name of the questionnaire for depression now in the elderly, because they have questionnaire that can also help to detect that. Once I remember that, I would mention it. So that could also come together. Then the stigma. The stigma is a big one. That's the truth. Sometimes people even try to hide their elderly ones because they can no longer remember things, or there's incontinence, there's bowel incontinence or urinary incontinence, and then they are ashamed to mention that and things like that. But I think that if they get the care, if they get proper care, then the quality of life for them will be good. Proper care, sometimes, I mean, it can be overwhelming. So if we need to employ people to the house to come help clean them, or more family members around, or even taking them to care homes, nursing homes that we trust, then that would also be very helpful. So the stigma has always been there. And I think one of the ways in which the stigma can be dealt with is what we are doing now, the awareness. The aspect of calling somebody a witch and things like that, a lot of times it's because of mental health problems. They are psychotic, and not even apart from psychosis, some of them can with psychosis, some of them can have what we call delusion of guilt. Now, delusion of guilt has to do with things like feeling guilty over something mild they have done in the past. So something mild they have done in the past now really becomes accentuated, like forgetting to give the daughter a medication at a young age, and then afterwards, maybe the daughter didn't get well, then they took the daughter to the hospital, possibly because they missed a dose. They can now start saying that they are the one that killed their daughter. Meanwhile, they are not the one. But the guilt that comes with that, oh, I forgot to give a medication, this person was really ill, we took her to the hospital, she didn't survive, and things like that. And then somehow, maybe they have even resolved that over the years. Now, when they become psychotic and depressed, there's something we call psychotic depression. They could have delusion of guilt, and then they start saying many things that they have not done. And so the Yorubas will say something like, she's a witch, and then they start stoning and things like that. A lot of times, these things are psychosis. And so, making people aware of this can also be very helpful. The awareness will help reduce the stigma for them to know that mama needs hospital care, not to stone her or to blame her that she has done such things. Okay. I hope I've answered your question.
Yes, ma'am. Thank you very much. So,
Can we have
more questions so that we can best contribute?
More questions? Is my slide still on, please?
There's a question in your chat box.
Okay, so 1 minute. I'll go there now. Am I still sharing my slide, please?
No.
Oh, okay. 1 minute. Okay, so question in my chat box. Okay, charts. Geriatric depression scale. Thank you very much. GDS, that's the name I was trying to remember. Okay, is there a relationship between menopause, dementia, and schizophrenia? Okay, this is a jam question. Okay, is there a relationship between menopause, dementia, and schizophrenia? So starting with menopause, we understand that menopause happens as people age. Generally, as people age, then they become menopausal. So I mean that occurs with age, really. I'm not really sure of any relationship between menopause and dementia. I'm not sure of any relationship between that. But generally, as people age, they enter into menopause. So, which is understandable that, that can happen. Now for dementia and schizophrenia, research has actually shown that, people with schizophrenia can have a higher risk of developing dementia than the general population. And that's for different reasons. One is that people who are being managed for schizophrenia, sometimes because of the psychosis, if they have other medical health problems, they might actually not pay attention because of the abnormality of the mind and thoughts and all that. They might actually not pay attention to their physical health. That's one major part. They might not pay attention to their physical health. And when they don't pay attention to their physical health and they have conditions like hypertension, conditions like diabetes, then that can happen. Aside that, also Alzheimer's on its own and schizophrenia, I think some genes have also been linked. So some people have mentioned that there could be an increase in the risk of developing degenerative diseases. So some people, some research have found that out. So there might be, or I think there is, some form of relationship between dementia and schizophrenia, especially for people who have schizophrenia as well as physical health problems. Also, the part of the symptoms of schizophrenia, some people, let me start this way. Those that use psychoactive medications, psychoactive substances, not medications now. Good example is cannabis. Someone who takes cannabis heavily is more likely to come down with schizophrenia. Now, apart from that, so that's one, I want us to know that. The other one also is that with schizophrenia, some people try to medicate their symptoms with psychoactive substances. So they tend to abuse psychoactive substances. And some of these psychoactive substances have also been associated with developing physical health problems that can predispose or that can be a risk factor to dementia. So when they take large quantities, it could predispose them actually. So with that risk, that is also a possibility that comes in there.
Thank you, ma. There's another question in the chat box.
Okay. Let me see. Is cognitive impairment synonymous to dementia? I would say yes and no. So let me start this way. So there's something called mild cognitive impairment. Mild cognitive impairment on its own is not dementia. But people that finally develop dementia often start with mild cognitive impairment, and then it further worsens into developing dementia. It further worsens into developing dementia. So with mild cognitive impairment, it's good that we ensure these preventive measures that has been mentioned before, ensuring good mental activity, ensuring good physical activity, ensuring that your blood pressure is being controlled and things like that. That's really, really very important. And then if we look into these preventive measures, that can reduce worsening worsening of the mild cognitive impairment, how fast it worsens. That can reduce how fast it worsens. Then for medication, it's better that you don't start medication until the diagnosis of dementia has been made. If diagnosis of dementia has not been made and it's just mild cognitive impairment, I don't think medication is necessary at that time, apart from medication needed to ensure your blood pressure, blood lipids, and all that are well controlled. So it's better, because there are some people that will just have mild cognitive impairment even in old age and would never develop dementia. So it's when the diagnosis of dementia is made, that's when we now go into pharmacological therapy. That's when we go into medication. Then between neurologists and psychiatrists, who should manage dementia? I would say both. Both neurologists and psychiatrists manage dementia. That's the truth. I mean, for someone who has been managed for Parkinson's before, the neurologist was already managing the person for Parkinson's, and even things like Lewy body and all that. Now, if they now come down and develop dementia, sometimes the neurologists just move on and continue to manage the dementia. I mean, Parkinson's dementia, and then they just continue to manage it if the person finally develops dementia. Same with Lewy body dementia. And then sometimes we also work together. We've had situations in which neurologists also request our input as psychiatrists, and we've had situations where we psychiatrists also request the input of neurology. So I believe in that aspect, we both kind of work together depending on where first, who the patient meets first. Okay. So I think I've answered that question. Are multivitamins and supplements relevant in the management of dementia? Okay. So dementia, part of the causes of dementia, I left that out intentionally. Though I think that can be reversible. There's the when there's vitamin B12 deficiency, people can actually begin to develop cognitive impairment, and some even progress to dementia. So, I mean, if it's as a result of vitamin B12 deficiency, then it's just better to correct that. It's better to correct that. And then multivitamins and supplements generally, I would say that if we eat balanced diets, we might actually not need supplements. If we eat balanced diet, we would also have, vitamins in it, such that we might not need multivitamins. But if it's as a result of, things like vitamin B12 deficiency, then specifically, it's not just about the person taking multivitamins. It's about, the person being specifically managed for that vitamin B12 deficiency, and which would have to be administered to the patient. Okay, I hope I answered that as well. I don't know, we are not speaking. Basically, we are putting on the chat box, but that's fine. Any other questions?
Any other question, please, so that we can round up by 9:20. Any other question or contributions to the house?
Okay, while we are waiting for questions, since you can see my slide, I will appreciate if while we're waiting for other questions, if there are questions, if we can scan this QR code, I mean, in just less than a minute, if we can give feedback on this lecture. Well, not lecture, sorry, the presentation, the seminar. We can give feedback. Thank you very much, Dr. Juniyi. I appreciate your feedback. If we can scan this QR code and just quickly give feedback within a minute, we should be able to complete the questions, or less than a minute. if we are having problems with the QR code, I can also place a link in the chat box, and then we can click on it with our phones, just in case we are having problems with the QR code. I think the QR code should work, but if it's not working, I'll be sending a link right away. But we can still ask questions, please. Okay, so I just sent the link to the group chat in case the QR code is not working. Thank you. I appreciate the feedback. I would also love it in the, through the QR codes, that would give a better view, of what everyone thinks. Thank you, Mr. I don't know whether it's Mr. or Dr. Ajiboye for the feedback as well. Please also use the QR code. Within a minute, we should be done with the feedback. Thank you. Okay, I can't see any other question in the group chat, so I will. Okay, thank you, Mr. or Mrs. Durojaye. Thank you. So I will hand over to Dr. Oladunjoye now. Please, can you hear me? I'm handing over to Dr. Oladunjoye now. Can you take over? I appreciate the opportunity and everyone. Thanks for listening. Is Dr. Oladunjoye there? I want to be sure you are hearing me because sometimes it can be the network. Anyone there? Can you hear me? You can just type yes in the chat so I'll know you can hear me because
We can.
okay. So we're just waiting for Dr. Oladunjoye to round up. Okay, thank you. Thank you, Mrs. or Dr. Oluwatosin and Mr. or Mrs. Durejaye. I don't know whether to say doctor now or Mr. or Mrs. Okay. While we are waiting, we could scan the QR code or use the link for the feedback. And if we have more questions as well, we can take more questions. Okay. Thank you, Dickiness Solubun. I'm not sure what the problem is with Dr. Oladunjoye's network. I'm trying to maybe make a call to him so that I can just round up for us.
Yes, thank you very much. I'm sorry the network went off. So thank you very much all for joining, and compliment of the season, wishing you all a happy new year in advance. So the next meeting will be, this is done monthly. The next meeting will be in January, usually the last Sunday of the month. So we'll be coming with another interesting topics that will also educate us on different aspects of hypertension, hypertension related generally. Thank you very much. Let's have a good night. Thank you all.
Thank you.
Yeah,
Thank you
thank
very
you.
much.
Thank you.
Yes, sir. That.